guess it's just one little button. I can't seem to remember to push it every single time. Oh, well. But thank you, Kylie, for being there. Anyway, so malignant neoplasms, on the other hand, are very harmful. And I have to tell you that they're poorly differentiated. Now, what we're talking about when we say that somebody is poorly differentiated, not somebody, but something, a tumor is poorly differentiated. What we're talking about here is, and you learned this in anatomy and physiology. I don't know if you had to go around the lab. See, I had to do all the same stuff that you guys did. You have to go around. It's test day. And so there's all these little microscopes set up all over the lab. And you have to go and look in the microscope and tell what kind of cell you're looking at. And we know what kind of cells different tissues look like. So skin cells look different from muscle cells, and muscle cells look different than cardiac cells. But we can tell specifically how that cell looks and what kind of tissue it is, because it's very well differentiated from other cells. Well, a cancerous malignant cell is not well differentiated. You can't really tell what kind of tissue it is that we're looking at. And so that's what we refer to when we say it's poorly differentiated. We cannot tell what kind of cell it came from or what its tissue of origin was. It's poorly differentiated. The problem with it too is that the cells will continue reproducing, and so they can actually invade the cardiovascular system, some of the vessels of the body, and then they just get in that little bloodstream and float at different parts of the body, and then they'll cling to a vessel wall and reproduce through that, grow through that vessel wall and into that tissue, surrounding tissue, and have another tumor site begin, and that's called metastasis. So malignant neoplasms are very, very dangerous because they can grow anywhere, and they can not necessarily grow anywhere. There are some tissues that they prefer to grow to and adhere to, but they can travel and start spreading the cancer throughout the body, and that's why they're so difficult to manage. And so also when I say then that when we're talking about poorly differentiated or well differentiated cells, which would you prefer to have, a well differentiated one or a poorly differentiated one? Yeah, we want a well differentiated one, always. All right, so the thing about it is that the early detection of cancer can come from several different things. And first of all, the major risk factors are that there is some chronic irritation causing this or stimulating this growth of new cells. So you think about this for a minute, that chronic irritation can come from different things. So can you think of some of the different disease processes that we talked about throughout the semester that may cause irritation to the surrounding tissue, not issue, but tissue? See, I have to put down, it's right here. Oh, scroll. Rheumatoid arthritis, yes, but rheumatoid arthritis is a synovial membrane or a synovial joint issue. What else do we have? What about ulcerative colitis? Yes, diverticulitis. Exactly. What else? What about GERD? Got some irritation going on there. Remember, I talked about that when you have this constant burning of the stomach secretions into the esophagus, that irritation will constantly inflame it, and you can develop scar tissue, or the tissue itself is so strange. The tissue itself will change. It will kind of adapt, and then that tissue becomes very susceptible to esophageal cancer. Kim. All right, let me think about it. What about smoking? Yes, smoking is an issue too. Why? Because that toxin that you're smoking will constantly irritate the lungs too, and make them very susceptible to cancer. So this chronic irritation is a huge factor in the development of cancer. Just so that you know, of course, there's always going to be a genetic and familial component to the development of cancer. So if you have a family history of colon cancer or breast cancer, prostate cancer, then you have a huge risk of developing the cancer. And then there's, of course, carcinogens, dietary factors, which can contribute to the development of cancer as well. So let's look at some exposure to some different carcinogens. For example, viruses. There are viruses that tend to be a precursor to cancer. For example, Epstein-Barr virus is a precursor to Burkitt's lymphoma. Herpes simplex 2 usually is a precursor to cervical and penile cancers. HPV and Hep B usually are a precursor to liver cancer. There's also physical agents. Sun and radiation are precursor to what? Melanoma. Yes, there are actually 3 different kinds of skin cancers. There's melanoma, which is the most deadly one. And then there's squamous cell and basal cell. And those are so very slow growing that they don't really offer much concern. But it's the melanoma that spreads so quickly. There's also chemical agents that are precursors to different kinds of cancers. We know tobacco and asbestos are huge precursors to lung cancer. There's other hazardous chemicals that are associated with the development of cancer. And then there's hormonal agents. So there's endogenous and there's exogenous, which is external. But for example, endogenous, you're talking about estrogen there. If you are given, you're postmenopausal, and you're not, as a woman, you're not developing estrogen anymore. And so the physicians will give you some synthetic estrogen. And the problem with that is that it often leads to breast cancer. And so that's why they always ask, are you on any kind of hormone supplements, or are you on estrogen for postmenopausal women? So just be aware that there are things that are considered risk factors in the development of cancer. So there's 7 safeguards that we want to practice to have an early detection of cancer. And the reason why we want to do this is that the earlier the cancer is detected, then the greater chance you have for recovery, because the cancer remains, the tumor, the growth, the neoplasm remains pretty small, and it's correctable. It's a lot easier to correct. So we want to be on that lookout for cancer, especially if we have any of those previous risk factors that we talked about. So there's monthly breast exam and testicular exams. Now, I have to tell you that the guidelines for that has changed over the years. In fact, are you ready for this? Are you ready for this? That in our comprehensive health assessment that you guys learned at the very beginning of the semester, if you can remember that far back, we used to include a teaching for a monthly breast exam and monthly testicular exam. And that was part of that comprehensive health assessment. But what they have found, research has shown that monthly breast exams, monthly testicular exams, when they're self-administered, don't have that much of an impact or resolve any of the morbidity and mortality statistics associated with those interventions. And so really the most likely exam is performed by the physician in a doctor's office when the cancer is detected. And so the thing about it is that we took that out of the comprehensive health exam. Aren't you so glad it was just one more thing you didn't have to do? But because it wasn't as viable as it used to be. But again, they're still in there, depending on the preference of the doctor, whether they teach to their patients how to do breast exams or testicular exams is really their call as to whether they want to continue to teach that at all. Smoking cessation will always be number one as far as what you can do to help to prevent cancer. Colonoscopy exams are annually given over the age of 50, but I got to tell you, my daughter developed colon cancer at the age of 36. It's getting to be younger and younger, and they really don't know why. But they're changing the time for that to over the age of 40. But again, if you have a family history of cancer, for example, if a woman has breast cancer at the age of 39, then her posterity should start getting exams when they begin at the age of 29. My daughter developed colon cancer at the age of 36. Her children should be starting to get checked for colon cancer at the age of 26 and have some colonoscopies then. What a thing to be looking forward to. Okay. Pap smears should be given to sexually active women. And of course, avoiding sun exposure and wearing sunscreen at all times when you're outside in the sun. Having regular dental exams. What the heck is that all about? Why in the world do we want to have dental exams? Steph had a question about Vicki. Okay, wait. Okay, so people who are burned, since they are making more tissue, are they at higher risk for skin cancer? Their skin is so fragile, yes. Yes. They have very fragile skin. Now, that being said, you have to look at if they've gotten skin grafts, or if their own skin has replaced the tissue that has been lost. But it's very, very fragile. And melanoma is developing in the melanocytes in the skin. And so, again, there may be some disruption that is going on there because of the skin graft. So, yes, you have to be very, very careful with that. Okay, so where are we going on? Regular dental. Oh, why does regular dental exams, why do we include that in an early detection of cancer? Because of oral cancers. Thank you, Mark. Sounds like you gave up your chew for that. It's true. People that chew in Oklahoma, we chew a lot. Yeah, everybody chews. In fact, I had to threaten a student that he was going to have to get kicked out of clinicals if he didn't quit with his chew. Always had a little bit of chew in it. Oh my gosh, it's so disgusting. But anyway, yes, chewing tobacco or smoking even can cause oral cancers. And then, of course, regular exams for all adults is helpful in preventing or detecting early signs of cancer. So this is a little, acronym that we want to use here, caution. So if there's ever a change in bowel or bladder habits, then we need to notify the physician. And, it's the same thing as with this coronavirus. And you say to yourself, what the hell is she talking about? Coronavirus and cancer. Thing about it is I said to myself, I don't have corona, but I don't feel very good. And it's just like, I don't want to look stupid, but at the same time, I want to protect my students. It's all about you guys. So it's like, okay, I'm going to go ahead and do it. It's the same thing that happens when you're thinking something's not right. I need to go see the physician, but you really don't want to. Spit. Ooh, Kim. Ooh, Kim. Ooh. Anyway, so the thing is that a lot of people have a change in bowel or bladder habits, or they have a sore that doesn't heal, or they have unusual bleeding or discharge, and they think, this could be cancer, but they don't really want to deal with it, or they don't, they're pretty sure they don't have it, and they're afraid that they do have it, and they don't want to know that they have it. So there's a lot of back and forth that you go through about, should I get checked? Should I get checked? And the thing about it is that I was more surprised than anybody else when I came back positive for COVID, because I was sure I didn't have it. And so holds true for patients that have some warning signs going on, but they're convinced they don't have it, so they don't get tested. So this is why it's so important that we become very, very familiar with these warning signs and to recognize them as warning signs, so that we can go and get checked, and so that early detection will stop the progression of the disease. So do I want you to know these things? Yes. Do you think one or two of these are going to be on the test? That would be a yes. Yes. So caution, let's read it again. Change in bowel or bladder habits. A source that does not heal. Unusual bleeding or discharge. T is a thickening or lump in the breast or elsewhere in the testicles. I'll say it out loud. We never put it on the slides, but I'll say that word out loud, testicles. I for indigestion or difficulty in swallowing. O is an obvious change in a wart or mole, and N is a nagging cough or hoarseness. Okay, so the thing about the characteristics of cancer cells are, first of all, a lack of contact inhibition. So when a normal cell is reproducing and growing, then when they come in contact with another cell, then that kind of signals them to stop growing. But a cancer cell lacks that. So that's what we call contact inhibition. They don't have any inhibition. They don't care. If they want to continue to grow, they'll continue to grow and just squish that other cell out. A lack of adhesiveness means that the cells don't adhere to each other. So how many of you have prepared chicken, and then when you pull the meat apart, you notice that the tissue kind of sticks together really well? Well, that's the adhesive quality of cells. But cancer cells lack that quality, and they can break off or shed with the least amount of disruption. So, and that's how metastasis is so easily achieved, is that there, we can disrupt that tumor or that neoplasm there. Piece of it can fall off, and boom, it's traveling, and it can start to grow someplace else. And then poor differentiation, we've already looked at that. It's when it's viewed underneath the microscope, the cells are very immature, that you can't tell what kind of cell it is. Okay, so there are some different stages of cancer development. And so we're going to go over that quickly. So when we have the initiation phase of this, anything that can penetrate the nucleus of a cell will change its DNA. And then promotion is when that change enhances the cell's growth, and it begins the initiation of the process. And then the progressive stage is when there's a continued change of that cancer scale, and the tumor begins to acquire malignant features. Now, not all of cancer cells will progress to that point, but some do. And then metastasis is when there's a secondary tumor that starts growing at a different site in the body. All right, so here is another little study guide for you so that you can compare the characteristics of a benign cancer cell with a malignant cancer cell. And why do I put these on here? Why do I love these charts so much? Well, because it's an easy study for you for the upcoming test. All right, so how does cancer get diagnosed? Well, you're sitting here and you don't know you have a growth somewhere. Maybe you've noticed it at the base of your neck, or maybe underneath your arm. And we look at it and we touch it and we feel it. And the thing about it is that cancer lumps, if we talk about lumps, remember we talked about this clear back when we were talking about hematology, was that a cancer cell will be firm and non-movable. So in other words, it's growing into the tissue. So we can kind of guess, and especially doctors who have a lot of experience with palpating lumps can have a educated guess onto whether or not it is benign or malignant. But the thing about it is that the most and the only way, really, the only way you can determine if a lump is a benign cancer or if it's malignant cancer is through a biopsy. Now, again, you can take an educated guess if you do a clinical history on the patient. There's other diagnostic study mechanisms. You can do an MRI, an X-ray, CAT scan, or ultrasound. Sometimes they will do a EGD or a colonoscopy or a bronchoscopy. And then they can also do a CBC and some tumor markers that we're going to talk about a little bit later, where they look for specific tumor markers in the blood. So this is how we diagnose cancer. But again, the best and probably the only way to really determine if tumor or neoplasm is benign or malignant is to do a biopsy on it. Now, when you are getting that biopsy and you're looking at the cells, then you are going to name that tumor by the name of the tissue that it is derived from. So let's move on here for just a minute. So when we talk about cancer, usually we always use the suffix "oma." What does "oma" stand for? Tumor. Yep. So it refers to a tumor or enlargement. So if OMA stands alone, it refers to a benign growth, but the prefix tells us what kind of tissue is involved. So if we're talking about a carcinoma, we're talking about epithelial tissue, and this type of tissue includes the skin, the glands, the digestive system, the urinary system, the respiratory tract lining. So example, there would be a squamous cell carcinoma. Carcinomas are actually the most common types of cancer. So sarcoma is relating to connective tissue or muscle tissue. So if we talk about osteosarcomas, then we're talking about what? Bone, exactly. Sorry, I have to switch back and forth to my little answers there. So blastoma, what are we looking for there? Neurotissue, exactly. Leukemia, we're talking about hematologic. We've already talked about that already. Blood cancers, plasma cells, bone marrow problems. Lymphoma is cancer that occurs with the lymphatic tissue. And then melanoma is a pigment-producing skin cancer. This is very scary because you really can't tell what's happening under the surface of the skin. Okay, so be sure to recognize which terminology refers to the benign tumor and which is the malignant tumor. So be very, very careful of that. Cancers are identified by the tissue affected, the speed of the cell's growth, and their appearance. All right, so another way to classify tumors is, here, this is my grandson.
Hello.
Yes, he's saying hello. He's taking my other computer away. Okay, so let me get where I'm at. All right, so the other classification that we're looking at is called the TNM classification, and so this is where the T stands for the tumor itself, and the N talks about the lymph node involvement that is associated with that neoplasm, and then the M talks about its metastasis qualities. So for T, and if you'll notice, the TX NX, MX all means that it cannot be assessed. So anytime you see an X in there, there's going to be, it's not assessed. 0, T0, N0, M0 means that there's no evidence of a primary tumor, no metastasis to the nodes, and no distant metastasis. And then T1 through 4 talks about the size of the tumor. N1 through 3 is the increasing involvement of the number of nodes that have been affected. And then M1 talks about that there is at least one distant tumor that has been found or secondary tumor. So this is the most common for staging a tumor in the American Joint Committee of Cancers definition of classification of tumors. So if, let me see if I can find my notes on here for just a minute. I want to give you an example so that maybe you can, let's see if you can figure this out. So if I gave you the following tumor classification, I want you to tell me what kind of tumor we're looking at. So this is a T4, N2, M1. T4, N2, M1. Tell me what I just told you. And everybody's gone for breakfast. Primary tumor increasing in size with nodes and metastasis. Nice job. The person has a large tumor, has moderate node involvement, and the tumor is metastasized. Exactly right. Okay, here's another one. A T2, N0, M0. Large tumor, no nodes or metastasis. Perfect. Exactly. So this is going to help you a lot when you hear that again. So do you think by any chance that a question with this type of tumor classification system is going to be on the exam? I'm just asking. Think so. So these are a couple of slides that you want to star. All right, staging describes the extent of the cancer. So you can have a stage 0, and usually a stage 0 is a carcinoma in situ for most cancers, meaning the cancer is at a very, very, very early stage. Not all cancers are going to have a stage 0, but then there's also staging of a stage 1, 2, or 3. Stage 4 indicates that the cancer has spread to a distant part of the body, so it is metastasized. So stage 4 is really, really malignant and poor prognosis. My daughter, when she was diagnosed with a stage 3 cancer of the colon, so the cancer tumor had grown through the wall of the colon and had just barely started to adhere to the abdominal wall. And so she was a stage 3. All right. Okay. So grading talks about the cellular aspects of the cancer. So if you have a grade 1, it means that it's well differentiated and closely resembles the tissue of origin. So is this going to be good? A good prognosis? Yes, it is. Yes, it is. And Amy was typing as fast as the little fingers could go. Grade 2 and 3, it becomes more undifferentiated. Is that really correct grammar? I don't know. And grade 4 means that it's poorly differentiated. and it tends to be much more aggressive and less responsive to treatment. So there's different kinds of classifications for tumors, and really you become familiar with which classification system your doctor's preference is, but always, if there's ever a diagnosis of that, then you want to have the physician clearly explain to the patient what that classification means, exactly what it means, so that the patient totally understands. Oftentimes when they hear the word cancer, it's very overwhelming, and they find it very difficult to process further information because they're stuck on that one point that they've got cancer, and they don't understand the rest of it. So you need to make sure that that patient understands the classification and the prognosis and that type of thing. I think one of the first things I did when I found out my daughter had her cancer was to go to the internet and find what the survival rate was for this particular kind of cancer. And I was very pleased to note that it was greater than 80%. All right, so what do we do for somebody that has cancer? First of all, we can do different kinds of surgery. Now, this should be somewhat familiar to you from way back in fundamentals, or at least I remember teaching it when I was teaching fundamentals, is that there's different kinds of surgery. First of all, there is, hold on, okay. Okay, I'm reading two different things. I'm sorry. Okay, so the first type of thing is, first thing that we want to do, there's different types of surgeries that are used with regards to cancer. For the number one surgery, of course, is to remove the tumor. And then, and get rid of the tumor because it is compressing or damaging surrounding tissue. Anyway, so, and we want to do that. Now, sometimes there are tumors that maybe run along the spinal cord there, but it's not compressing the cord. It's not causing a lack of function. Maybe there's no pain associated with it. So the doctors are very happy to leave it in place, as long as it's not damaging, because the risk for damage to the cord or the surrounding tissue is much greater than leaving the tumor there. So, like I said, surgery is not always definitely recommended for removal of a tumor, but in most cases it is. A prophylactic surgery means that we're going to remove it before it starts to develop. You look at things like that, you're looking about a polyp removal for a colonoscopy. You know, little polyps will develop into little tumors, and little tumors grow into big tumors, and big tumors block the and obstruct the intestinal tract. And so prophylactically, we're going to go in there and remove that polyp before it develops into something major. Same holds true with precancerous tissue. Palliative surgery is that we're going to go in and remove some surgery or some tissue or removal of some organ or something so that it is more comfortable for the person. There's less pain involved maybe, but it's not going to cure the cancer. And then reconstructive surgery often happens with people that have cosmetically been disfigured from the cancer, and we're going to go in and try and do some reconstructive surgery to make their appearance more pleasing to them, aesthetically pleasing. Now, surgery is just one way for treating cancer. Another way is radiation. Let's see what we've got going on here. Radiation. So the thing about radiation is that it can be external or it can be internal. So the thing about radiation is that it damages tissue. Yes, it does. So let's talk about external radiation first. So a lot of times there will have a specific place on the body that needs to be radiated. My friend had a parotid gland cancer on the side of her face. She was diagnosed with that in June, and in August she went to have it removed. And by the time she went in to have it removed, it had grown down her face and then into her neck, and it was right there by her carotid artery. And so when they went in to remove it, they took out the muscle in her cheek, and they took out half her neck, literally the muscle in her neck. So she has a very asymmetrical neck, and her neck gets very, very tired from holding the her head all the time, and she has to sleep with a special pillow because of the lack of muscle on this side of her face. She did have some external radiation, which really caused this burning of the skin. And the radiation went in, and of course it deals with the tissue underneath. And so the radiation caused her to lose all her saliva glands. So she has to consistently drink water because she has dry mouth all the time. And she lost all her taste buds as well. So she weighs a whopping 88 pounds now. But you know what? She has survived this cancer for over 20 years. It's a miracle to me. So external radiation is very, it's like Chernobyl, you know, it's affecting your skin here and the tissues underneath. So again, because you're going to have very tender, burnt skin here, you want to wear very loose clothing over that area. And you just, when you wash it, you don't use it with soap. You just very, very, it says on the slide to use mild soap, but it's just with a cool, tepid rag, and you pat dry it. And if there's any ink markings or dye markings where the radiologist has determined the radiation should pinpoint, be exactly where the beam of the radiation is to be focused, do not scrub those off. They need to be there permanently so that they can be used as landmarks in the radiation process. So when you have external radiation, you don't want to use any powders or ointments or lotions unless they are prescribed by the radiologist. Avoid any pressure, use cool, moist compresses, and avoid exposure to the sun, and avoid swimming in chlorinated water because it's going to burn. It's going to burn even more to that very damaged, tender, fragile skin. So brachytherapy, on the other hand, is internal radiation. Now the question says, okay, not the question says, but I wonder where I heard this question before. I'll have to really think hard about that. I don't remember. But when a person gets external radiation, you know, with those little lasers, then the person is not radioactive. However, when a person receives brachytherapy, which is internal radiation, then the person becomes radioactive and is a threat to anyone that is standing within 20 feet of them. So what we do here is that when you have a certain kind of radiation, and a lot of times they'll do this for people that have prostate cancer, they will stick these little beads or beans of radiation into the body, and then a radiation comes internally to the tissue that it's surrounding. And everything in the body becomes radioactive. And so that radiation is eliminated in the waste products of urine and feces. And so we have to be very, very careful the way that we handle patients on brachytherapy, because we can expose ourselves to it. So there are certain guidelines for nursing care of persons receiving brachytherapy, and let's go over those. First of all, the person is going to be assigned a private room, because anyone within the vicinity, you can see this right here, this little chart right here, gets exposed to that radioactive material. So you have to put a sign out on the door so people are aware of it. You keep the door closed at all time. And as the nurse, you're going to wear this little meter on your badge that lets you know all the time what your exposure is to the radiation. And you need to wear a lead apron whenever you're caring for the patient. Now, this is one time where the rule of thumb is that if you have a patient on brachytherapy, then you are going to minimize your contact with that patient. And you need to inform the patient of that before they ever get the beam stuck in them. You just have to tell them, this is because you're going to be radioactive. My care will be as necessary. It is minimized. So when you go in to check on your patient, basically you're sticking your head in the door and just saying, how are you doing? Okay, good, great. And that's it. But you have to be very, very careful of how much time you spend in with your patient, because it's going to make all the difference in the world. Pregnant nurses should not care for a patient on brachytherapy. Do not allow pregnant women or children under the age of 16 in to visit the patient in brachytherapy. And you have to limit visitors to 1/2 hour per day, and that they're sitting 6 feet away from the patient. Social distancing has nothing on these patients. You never touch the radioactive source with your bare hand, and you dispose of it into a lead container. And the oncology floors will have these special containers for this very purpose, and save all the dressings and bed linens until after the radioactive source has been removed, so you don't wash them with other people's laundry. Okay, any questions about that? Oh my gosh, it's 10 after 9. Let's take a break. Let's come back at 9:20, and then we'll finish this little baby up. Okay, we're back. Stephanie asked the question, how long are patients usually under this therapy? It all depends what's going on. They may have low dose therapies where you go in and you have a cup, you have the exposure while, for example, a catheter is inside of you, and you may have it for 15 to 20 minutes, and then the catheter is removed. And that may go on a couple of times a day, or it could be a long-term therapy where they implant these little seeds into your little body, like I told you, and it would be long-term, and sometimes it's permanent. And then after a couple of weeks, the seeds are no longer radioactive. So it really depends on the kind of cancer, how much radiation is required to kill the cancer, how much tissue is involved, and the doctor. So I don't know, basically. Don't know some of it. Anyway. All right, so the last thing that we're looking at is chemotherapy. So we talked about there is surgical removal of a cancer, there's radiation, and then there is, of course, chemotherapy. And to understand chemotherapy, we have to kind of go back to our general anatomy and physiology and talk about the cell cycle. So if you remember, there's a G0, G1, S, G2, and M. So this is how a cell divides and replicates. And so there's these different stages here. Well, different chemotherapy agents will affect the cell cycle at different points. So, and this holds true for neoplasm as well. You have this accelerated reproduction of cell or replication of cells, but those cells, the tumor cells, go through the same cycle as a regular normal cell. So what we're trying to achieve with chemotherapy is to stop the replication of a specific cell. However, the problem with chemotherapy is that if you are targeting the G1 phase of the cell cycle and stopping the reproduction of the cell at the G1 phase, it's not only going to affect the tumor cells, it affects live cells as well. So basically what we're doing with chemotherapy is we're trying to kill off all the neoplasm cells before we kill off all the healthy cells that are reproducing. Yeah, not very fun. Can you understand why people get so dang sick? Is because we're killing off good, healthy cells as well. So what we're trying to do, and oh my gosh, who came up with this? I don't know. But we're trying to stop the replication of the neoplasm, and at the same time, before we kill off all the healthy cells. It's a crapshoot. Best way I can tell you that. So the thing about chemotherapy is that you have to be chemotherapy certified to administer chemotherapy. And so we did this when I was working in the PICU. Everybody became chemo certified because you were administering chemo a lot. And there's a lot, oh my gosh, you wear all this protective equipment to protect yourself from the fluid or the chemotherapy getting onto you and getting absorbed through your skin. So the thing about it is that when a person has been on chemotherapy or receiving some of these toxic fluids, then you have to place the patient on special waste disposal precautions for 48 hours after they've received the chemotherapy. So you do put a sign on the door. You wear these special heavy rubber gloves that you use whenever you're handling the patient's secretions. If they're too sick to get out of the bed to go to the bathroom and they use the bedpan, then you want to wear these heavy gloves, heavy rubber gloves. You always want to flush the toilet 3 times after you've disposed of any waste material into the toilet so that it all goes down the toilet. We want to label all specimens, chemotherapy precautions, so that people know what they're handling, because we don't want any chance of that to being absorbed through the skin, because then it's going to affect your skin or your cells in the same manner that it affects that person with cancer. Also, and you know, chemotherapy, the kind of chemotherapy that is used will determine exactly the precautions that are used and what is necessary. I remember back in the day that, we administered this in the PICU. When my daughter had her cancer, and after she had a couple of feet of her colon taken out, and she had a port put in. And so back in the day, they would do an infusion of chemo for 3 hours or 4 hours, and then the person would come home and be sick as a dog. Well, guess what? They all managed. It's all different now. And my daughter came home with this little backpack, and she had a pressure bulb pump infusion that was infusing her chemotherapy into her port, and it was inserted into her port at the doctor's office, and she stayed there for an hour, and then she came home where it finished infusing within 48 hours. And then she went back to the doctor's office and had it removed. But by extending the length of time that the chemo was being infused, she didn't get nearly as sick as she would have had she had it delivered within a 3-hour period of time. She was on 5-FU, was the kind of chemotherapy that she got. I thought FU was extremely relevant at the time. Anyway, so she also came home that first time with the box, big old box, that was a hazmat suit. So in case she got disconnected from her port and there was leaking this chemotherapy all over the bed, then she was given her gloves and goggles and all this stuff to wear. And then she'd have to notify the doctor's office. So, a lot of changes have occurred in the delivery of chemotherapy over the use to make it more palatable to the patients receiving it. It's so hard on the body. It is so hard on the body. Again, because it's disrupting the cell cycles all over the body, not just the cancerous ones. And so they're looking for ways all the time of trying to make it easier on the patients so that they can survive the very treatment that they're receiving to help try and get them better. All right, so you want to go, and I'm not going to spend a lot of time on this because you all are not IV certified yet. This is the state of Utah. I don't know why the state of Utah is this way all over the country. LPNs finish their education with having knowledge of IV insertions, and for whatever reason, I don't know why Utah doesn't. After you get licensed, you can become IV certified. So it is definitely within the scope of your practice as an LPN. However, as a chemo nurse, you do have to be RN licensed to administer chemo. So there's some rules for it, and I'm not going to hold you to that because in this particular curriculum, it's not within your scope to deliver IV medications. So what are some of the problems that you're going to have for a person that has cancer? First of all, you're going to have anemia. Of course, you're going to have anemia. Now, here, people, I want you to listen to me. How many times have we talked about anemia throughout this semester? And you had it last semester as well. So we've talked about it a lot. Yes, thank you, Kim. Yes, a lot. And guess what? Everything is the same. Signs and symptoms are the same. Interventions are the same. And guess what? This is a fabulous review for your final. Yes, it is. And this is one of the reasons why we have the immune system and cancer and HIV at the end of the semester, because so much of it is a review of the semester's interventions and signs and symptoms so that you can prepare for the final. Like I said, this is nothing new. This is all a review so that this shouldn't be too hard for you. So you do, with anemia, you want to monitor for lightheadedness, dizziness, izziness, and syncope. You want to assist them in the shower. Why? Because the shower is going to vasodilate those vessels. And if they're already lightheaded, don't have enough oxygen getting around, then, you know, they're going to faint. So we got to be especially careful in the shower. When they're ambulating, you got to have a person assist or supervise as necessary. Monitor their hematocrit, hemoglobin, and RBCs, drink plenty of fluids, and manage their fatigue. So, yes, it's the same. Nothing new there. Oh, diarrhea. How many times have we talked about that? Oh, I'm sure you got your introduction with Rachel and her poop day. Of course, you guys did not have the festivities that usually she thrives for. I thought she was going to absolutely go into this deep, dark depression because last semester, poop day only had 6 people in the classroom. Everybody else was at home. She didn't get to share. It was just very hard on her. But again, signs and symptoms are going to be the same. Interventions are going to be the same. Doesn't matter what's causing the diarrhea. It's all going to be the same. So monitor the frequency and the amount of stool. Get them on a low residue diet. Increase their fluids. Avoid caffeine, carbonated vegetables, very hot, very cold foods. Avoid milk products that cause gas. Monitor serum electrolytes. Provide anal care. Yeah. You've read it all. Constipation. Oh my gosh. How many times have we talked about that? Yes, we have. And just look at this, what we're going to do for these people. It's all the same. Nausea and vomiting. Yet again. How many times have we talked about this? 100 times. So here are your interventions that we're going to do for this. This should be easy peasy for you. Just reminder of these slides. Nothing more that you got to add to your notes here. Risk for altered nutrition. Have we talked about that? Yes, we've talked about that. I'm just saying to you, we've talked about that. So read. Yeah, it's the same. Alopecia, we have talked about that, but one thing that I wanted to stress, geez, why do I want to stress that? I don't really know, other than the fact that it probably happens on the test. Anyway, the thing is with alopecia, is that while you're going to talk to them, that they may have the potential loss of hair. My daughter, thankfully, did not lose her hair with the 5UK. Sorry, I was getting a little ahead of myself there. The 5FU. She didn't lose all her hair. She did thin. It did thin considerably, but she didn't lose it all. But her friend who was going through breast cancer at the time did lose all of her hair and her eyebrows and her eyelashes and every bit of hair on her body. But it is often suggested that the nurse suggests to the patient that before the person starts losing their hair, that they go to a wig shop so that they can match the color of their hair and the coarseness of their hair with the wigs, with a wig or two. So we just want to stress that, and I think I want to stress that because that's the option you should choose on the test. I think that's the only reason why I'm mentioning it. But I'm just saying. Okay, infection and neutropenia here. So this is where we put them under infection precautions. I know that you need to know these because you use them so often as a nurse. So you avoid contact with others, avoid crowds, frequent hand washing, avoid trauma to mucous membranes, avoid fresh fruits and vegetables, no flowers or plants with stagnant water. I think yesterday we with the HIV, with again, you have infection precautions there. It talked about cleaning, do not clean out the cat litter box, do not have turtles or other reptilian pets because they carry diseases. Why do I mention that? Oh yeah, seems to me it's on the test. But the thing about it is that these are the same precautions, same precautions. So again, does it matter the cause? No, the interventions are going to be the same. Sterile technique for invasive procedure, report increased temperature, monitor white blood cell nadir. Now, what is nadir? Anybody? Anybody out there? Hello? Hello? It's like the lowest cell count. Yes, it truly is. And the thing about it is that you need to be watching that white blood cell count every single day to see, because the patient is going to be at the greatest risk when their white blood cell is at its lowest. So, you know, when we sit there and say, okay, white blood cell count is a normal range is 5 to 10,000. Well, what if you have a patient who has white blood cells at 3,000? Does that mean that they don't have an infection? No, it means that they're at a great, huge risk for infection because they don't have anything to fight off that infection with. Okay, thrombocytopenia. So this is bleeding precautions here. Again, this should have been learned as fundamental. So just review all those interventions there. Continue with that. And stomatitis. What is stomatitis? That was on your little quiz today. Inflammation of the mouth. Thank you very much. And risk for reproductive or sexual dysfunction. And this is something, too, that sometimes you have to educate your patients on. For example, if you have a person that has going to be receiving chemotherapy, then before they start the treatment, they may want to donate eggs or sperm. And this is something that you have to be very frank with your patients about and educate them on. And why am I mentioning that? Because it just may be on the test. I'm just saying to you guys, because they don't know, they don't think along these lines about what is the consequence of this. They don't understand the cell cycle. They don't know the consequence of this chemotherapy. They're still concentrating on the fact that they've got cancer. They don't understand it all. So you have to be very frank with them and give them options, not tell them what to do by any means, but at least let them know what their options are. Okay. And then pain. And one of the things about pain that you have to address with somebody pretty early on is the fact that people are afraid of cancer so much is because they're afraid of the pain that they are going to feel. And some kind of cancers are more painful than others. And so working in tandem with the patient is very, very important, because to get that pain managed. If you're not working well with your patient and there isn't a trustful relationship there, then we're not going to be able to manage their pain. And it's sometimes very, very difficult. I had a friend whose husband was vice president of an oil company and very type A personality. Oh my gosh, very difficult to like. Got to just tell you. But anyway, so, and he was very stoic, and he had small cell, squamous cell lung cancer, and could hardly walk. He was 6'4", and his little wife is like 5'4". And she was having to help almost carry him into the doctor's office. And then as soon as he got in to see the doctor would ask him how his pain was, and he'd go, "Fine, I feel fine, nothing wrong with me." And it's just the doctor was so frustrated because he couldn't talk to him and manage. He knew that Val was in a lot of pain, but Val wouldn't admit to it. And so he couldn't really recommend any changes in the pain medication because Val wasn't real open to it. So it's very, very, very important that we discuss this early on with our patients, that we determine, get a sense for their fear and apprehension of what they're going to be going through, and make sure that we get them on an effective pain management regime. Okay, so here are different kinds and descriptions of cancer type pain and how some people have described it. So the thing about it is my daughter had an organ obstruction. It was dull, crampy, gnawing. She went to the emergency time, I think 3 weekends in a row, trying to get somebody. And because she was so young, they never considered in a million years that she had colon cancer. So they never checked her for it. And finally, on the third weekend, a doctor admitted her. But it wasn't until she, within a 12-hour period, her stomach went from being very flat to looking like she was 9 months pregnant because the obstruction was backing up into her stomach. Okay, so nursing care for patients with cancer, there's pharmacological measures that, of course, you're going to deal with the non-pharmacological measures. And again, you talked about this in fundamentals, so this should be pretty much a review for you. The opioids, just be aware that people in cancer pain that have grown tolerant of their opioids may be on large, huge doses of opioids that would kill you or I. But for them, their body has been able to adapt and to tolerate it to try and help manage their pain. So 200 mics of fentanyl per hour may seem like it would kill you and me, and indeed it probably would. But to somebody with cancer, it is just all in a day's work. All right, people, that's my lecture. There is one little last thing that we have to do. Our part, sorry, I got some ice. Hold on a minute. Hold on. See if I can do this. I don't know if I can do this. Yes. Okay, turn out the lights. Everybody turn out the lights in your room. Yes, I do this for every semester because I love my students. Because you guys have been the greatest joy of my life. So everybody turn on your videos for one. I don't care if you're still in your jammies. Mark Richards, if you are naked, just leave your video off. But if you guys are here, get your lights. Here we are. We're going to put on a little queen here. Make sure that we're turned up to max, because by golly, we got to bring out, we are the champions. Here we go, people. This is for you. Here we go. I'll get rid of this slide for Pete's sake. There we go. Mark Medina, you look fabulous. Put your face up there. Okay, people. are the champions, my friends. I don't sing. We'll keep on fighting till the bitter end. I know most of you weren't born back in the 70s, but you should have been there. Let me see if I can bring up Queen here. I don't know if I can.
Unfortunately, everything that goes with it. I thank you all. But it's with a bed of roses. No pleasure cruise. I consider it a challenge to follow your ways.
We are the champions, my friend. Okay, you guys, I have to just tell you, you are my champions. You are my champions. You survived. You did it. I love you guys. I do. I love you. I love you because you stuck it out. So go home, have yourself some Diet Coke or whatever you need to get through the rest of the day. And just hang in there till next week. Love you guys. Peace out.
Thank you for everything you do. You're amazing.
Oh, you're so. Oh, what is with this? A uniform? What is with this uniform? Pass-offs. Pass-offs. All right. Have a good one, guys. Love ya.